Hello, everyone. Welcome again to our Filling Your E&M Tank APCM review with interactive Q&A webinar. My name is Ashley Decoto, and I'm a specialist with our provider outreach and education team. On the call with me today is my friend and colleague, Leanne Foster, who will be helping out with the chat. This webinar is part 2 of our 2-part series on advanced primary care management, or APCM services. Yesterday, Leanne held the part 1 webinar that provided more of a comprehensive overview on APCM. Now, if you were not able to attend that session yesterday, the recording will be available within the next week or so in the training center of our website and on our YouTube channel. We will also have a recording of this session available also on the training center of our website, and Leanne will be adding a link for the training center to the chat. And it'll be out there on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube from work. The recording will also be available on our YouTube channel, and it will stay out there as long as this information remains relevant and current. Also in our training center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still available for download in case you'd like to have the presentation to follow along or to take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat. We did have quite a few questions that were pre-submitted with registration, and I will be answering those that relate to advanced primary care management throughout the presentation today. Now, if for some reason we do not get to live chat questions, we will be answering those in a follow-up email. Okay, for our agenda, we'll start out by doing a brief recap from Leanne's part 1 webinar yesterday, where she went into more detail on APCM services, including the elements of APCM and correct billing. Again, if you were not able to attend that session, make sure that you review the recording from the training center on our website or on our YouTube channel once those become available. Next, I will be sharing some claims data for APCM. We received a few pre-submitted questions asking for updates, and at this time, there have not been any recent changes to APCM, so there are no new updates to share outside of that recent claims data that I'll be sharing. Now, after claims data, the remainder of the webinar will be our interactive Q&A activity. And then I also wanted to mention that I have included some resources in the presentation, and we'll be going out to show you at least one of those. And these might be resources that you saw yesterday if you attended Leanne's part 1 session, but we really want to make sure that you know these are available for today's activity. All right, so let's get started with a review of Leanne's part 1 session. So advanced primary care management, or APCM, delivers comprehensive continuous care management to Medicare patients through a dedicated focal point of care. APCM provides longitudinal care, delivering ongoing monitoring, proactive intervention, and 24/7 patient access to support prevention, wellness, and care coordination. APCM is a monthly service billed by a physician or a non-physician practitioner who is responsible for all of a patient's primary care services and is the focal point for all of that patient's needed healthcare services. APCM combines the elements of other care management services, including those that you see here. So principal care management, or PCM, transitional care management, or TCM, and chronic care management, or CCM. Let's talk a little bit about each of these included care management services. First, principal care management, or PCM services. These focus on a single high-risk chronic condition expected to last at least 3 months and places the patient at significant risk of hospitalization, acute exacerbation or decompensation, functional decline, or death. PCM services require at least 30 minutes per month. The next one is transitional care management, or TCM, which helps patients transition back to a community setting after an inpatient stay at certain facilities. TCM services start the day a patient is discharged from an inpatient stay and then continue on for the next 29 days. We did receive a question with registration that just said TCM billing, and we aren't going into a lot of detail on TCM today, but Leanne and I do have another series like this one scheduled for next month on TCM, and I've asked Leanne to place the registration links in the chat for that. The last one on our list is chronic care management, or CCM. Now, CCM is another monthly service that can be provided to patients with multiple, meaning at least 2 chronic conditions. CCM is a proactive approach rather than a reactive approach to the patient's care, which would hopefully reduce emergency room visits and result in fewer hospital stays. Now, you may already be billing for any of these other care management services. APCM combines these services into a bundled payment. So if you decide to bill for APCM services, you would not also bill any of these other care management services separately. APCM also includes communication technology-based services such as virtual check-ins, remote evaluations of pre-recorded patient information, and interprofessional consultation. It provides overall comprehensive care management, and it delivers cares in alternative ways to office visits. It provides patients with a wide range of services to meet their individual needs, and you can bill for these services using a monthly bundle instead of billing for each individual service or recording minute by minute, since APCM is not a time-based service like some of the other care management services. So these services help simplify your billing and documentation requirements while also ensuring that your patient has access to high-quality primary care services. Now, you can bill APCM using one of 3 codes. Think of these codes as 3 levels with kind of increasing complexity based on the patient's care needs. The first level is code G0556, which is used for APCM services for a patient with 1 or less chronic conditions. The second level code is G0557, which is used for APCM services for a patient with 2 or more chronic conditions. And then the last code is G0558, which is billed for APCM services for patients who are qualified Medicare beneficiaries, or QMB, and have 2 or more chronic conditions. So these codes were established by CMS last year in the 2025 final rule. There is a link in the footer of this slide for the Federal Register, and I've also asked Leanne to place this link in the chat in case you have not downloaded the presentation. But this link includes details of APCM in the 2025 final rule. And this is by no means something that I'm asking anyone to read right now. But if you're interested in more of the background on APCM, there's a ton of information in that link if you wanted to save it to look at later. One interesting thing that I did find in there was about research, which has demonstrated that greater primary care physician supply is associated with improved population level mortality and reduced disparities, and also that establishing a long-term relationship with a primary care provider leads to reduced emergency department visits, improved care coordination, and increased patient satisfaction. So the research really has shown that APCM services are beneficial for the overall care of Medicare patients, and it can help simplify your billing. So that's a long read, but there's definitely some interesting information in there on the background of how APCM was initiated last year. Here we have some more information on what is included in APCM services. So first, you must have the patient's written or verbal consent to participate in APCM services. You will need to inform the patient that only one practitioner is able to provide and bill for APCM services, so they cannot receive these services from every practitioner involved in their care. You must let them know that they are able to stop receiving these services at any time. Also, be sure to let them know that cost sharing does apply, so they will be responsible for any deductible and copay amounts. Next, APCM services require an initiating visit for patients that are new or patients that have not been seen within the last 3 years. For the next item on our list, the billing practitioner must be the patient's focal point of care. So while CMS does not restrict APCM services to certain specialties, this is typically billed by primary care providers who are responsible for all of the patient's primary care services. Patients that receive APCM services must have 24/7 access to the provider billing these services or the care team under that billing provider's direction. And then lastly on our list, these services are typically provided by clinical staff under the overall direction of the billing practitioner. So next, I'll be sharing some claims data. So here we included some claims data for APCM. And as you can see, likely because these codes were just established and just became effective last year, these services are really not being utilized or billed very often yet. So our goal is to give you the information you need to start offering and billing for these services. We pulled data for both of our WPS jurisdictions, J5 and J8. And as you can see, we really don't have a ton of claims. We did not have any G0556 claims for that time period, and then not quite 4,500 for G0557, and only 30 claims for G0558. So we typically like to provide the top denials and rejections when we do these two-part series. And we're really only seeing two types of denials so far for APCM services based on this data that we pulled. Our top denial for APCM has been claims denied while the beneficiary is in a period of managed care. And this would happen when they are enrolled in a Medicare Advantage plan. So make sure that you check eligibility, which is something that you can do through our secure portal if you're signed up to use that. And if the patient has a Medicare Advantage plan, that claim must be billed to the plan. Original or fee-for-service Medicare does not process those claims. The other top denial is for payment already made for same or similar procedure. And this type of denial may happen when another provider bills APCM during that same month. So to help you avoid these denials, this goes back again to the patient consent, where you want to make sure to let the patient know that only one provider is able to provide these services. Another thing that could cause this type of denial is billing for one of the included care management services. For example, if you have already billed for, let's say, chronic care management or CCM this month, your APCM service would deny. Remember, APCM bundles payment for TCM, CCM, and PCM, so you can't bill for both APCM and any of these care management services in the same month. So since we had such limited claims data for APCM, we decided to include a few of the top denials and rejections for the care management services that are included in APCM to kind of give you an idea of what to look out for if you decide to start billing APCM services. Or maybe you're already billing APCM and might see one of these denials or rejections. So let's talk about each of these. We'll look at the left column first, which includes the top three denials for CCM, PCM, and TCM. First is one that we actually are seeing also for APCM, which is payment already made for same or similar procedure. So if you've already billed APCM this month, you'll receive this denial if you bill a second time. This could also happen if more than one provider tries to bill APCM in a single month. Same thing applies for other care management services. They are billed monthly and may only be billed by one provider. The next top denial is for the patient being enrolled in hospice. For patients in hospice, all care related to that terminal hospice diagnosis is included in the hospice care. For services not related to the hospice diagnosis, you'll want to bill with the appropriate modifier. Excuse me for just a moment, I have a tickle in my throat. So last for denials is units of service exceeded. APCM would only be billed monthly with one unit of service. Now, if you bill more than one unit of service, you would receive this type of denial. We see this denial more with CCM and PCM, which have time-based codes, including codes to bill for each additional 30 minutes. And CMS has established maximum units of service that a provider would bill, and those are called MUEs, or medically unlikely edits, and exceeding those amounts could cause this type of denial for those time-based care management services, again, like CCM or PCM. So let's move over now to the right column, which has top rejections for the other types of care management that are included in APCM. The top rejection that we've seen is clinic number missing or not entered accurately. For these, you want to make sure that you've included your clinic's NPI and that it is entered correctly. If you omitted the NPI or maybe you keyed it incorrectly, you would just make the correction and then resubmit your claim. For the next one, we have incomplete or invalid modifier. And you might see this type of rejection if you report a modifier that is not applicable to care management, such as maybe a surgery modifier or a bilateral modifier. Since these types of modifiers do not apply to care management services, appending them could cause your claim to reject. The last rejection we have here is for missing, incomplete, or invalid provider identifier. And these rejections happen if you're missing or include inaccurate information to identify your provider or facility. This could happen, or this could include, the rendering provider's ID number, which is your provider's NPI. It could be an invalid or missing tax ID number or your facility location. If your claim rejects for missing this information, or maybe the information submitted was invalid, you would fill in that missing information or correct any errors and then resubmit your claim. So I did include this slide here as a reference to help kind of summarize what I just talked about for your APCM and the included care management denials and rejections. For rejections, you'll fix the error and resubmit the claim. Remember that for rejections, the claim was not able to fully process, meaning a claim determination was not yet made and the claim does not have appeal rights. Those must be corrected and resubmitted. Now for denials, your next step will depend on the type of denial you receive, and your remittance advice will really be your best source to determine what's next. It may indicate you need to resubmit your claim, in which case you can correct the error and resubmit. And in some cases, you may be able to correct a minor error through a clerical error reopening using our Secure Net Access portal. This might be a keying error for your place of service or your rendering provider's NPI, for example. And then you'll have denials that will require you to appeal if you disagree with the claim determination. And your remittance advice would include remark code MA01 to indicate that you do have appeal rights. We did also include a link in the last bullet of this slide, which has some information on how to appeal a claim if maybe you're newer to that process. Okay, now we're going to shift gears into our interactive Q&A activity. And we've designed this to be kind of a fun way to test your knowledge on APCM. So I will be launching a poll for each question during this activity. And even if you aren't 100% sure on the correct answer, We'd love to have you participate and give it your best shot. I'll give you a moment to lock in your answers and then walk through the correct answer for each question. Now, for those of you who have attended our Q&A activity webinars in the past, I do want to make note of a slight difference you might notice today, or even for those of you who are new to these Q&A activities, I'll explain how to use our webinar software for these questions. So we will be using Slido within WebEx. And to find Slido, you will need to click an icon that has a little plus sign on it. It should be down next to the chat icon towards the lower right of your screen. And it will say Show Apps or Show Apps panel if you hover over it. Once you click on that button, it should allow for you to click on Slido, which again is the platform we'll be using for these poll questions. Now, before I launch the first question, we did have some pre-submitted questions asking for resources. This slide has some resources for our activity today, and Leanne will also be placing these links in the chat in case you haven't downloaded the presentation. And you're welcome to have these open to help out with our activity. The first two resources in particular are pages that I find particularly helpful. And these are the CMS APCM services page and the CMS FAQ. There's a lot of information within those pages that will be helpful for the activity. All right, for our first question, we're going to start out a little on the easier side and give everyone a chance to find Slido. So the first question is, which of the following are included in payment for APCM? And you can select all that apply for these options. Is it A, E&M visits, B, CCM, C, TCM, or D, PCM? I'm going to give it just another moment while we've got a few still getting their votes in, or getting their answers in, I should say. Okay, the answer is B, C, and D. APCM combines elements of other care management services, including CCM, TCM, and PCM. These care management services are bundled into APCM, so you would not bill both APCM and CCM, for example. Before we move on to our next question, I do want to take you out to one of the APCM resources, which is the first in the list of links for this activity, the CMS Advanced Primary Care Services page. Now, in case you were looking for this page, maybe after the webinar and didn't have the link handy, I will also show you how to find it. So I'm going to start out by going to the CMS website, which is cms.gov. I'm going to go right here to the search bar, and I'm going to type APCM, and I'll press enter, or you can click the search button. And what we're looking for should be the first search result, and it looks like it is. So I'm going to go ahead and click this link for Advanced Primary Care Management Services. So if you're new to APCM or considering offering these services at your practice, this page is really a great place to start. It provides you with a summary description of what APCM services are under the first tab. And then if I scroll down, we have who can bill right there, and how often you can bill. There's also a section on what the APCM codes are, which provides this nice chart laying out the 3 code levels. Below that, we have the billing requirements. And this is where you'll find all of the required elements that must be provided as they are clinically appropriate for each patient. And then we have information down below that, there we go, on auxiliary staff providing these services. And then if I scroll back up, it always takes me to the bottom of the page. Lastly, we have resources on where to find more information. So feel free to keep this page up to help with some of the remaining questions during the activity. And with that, I'm going to head back to the presentation and on to our second question. So this question is, which of the following are billable in the same month as APCM? And you can select any that apply from these options. Is it A, E&M visits, B, CCM, C, TCM, or D, PCM? All right, thank you all so much for answering that one. So the answer here is A, E&M. And we talked a little bit on the last slide about how you would not bill CCM, TCM, or PCM in the same month as APCM. Evaluation and management, or E&M visits, on the other hand, are not bundled into the APCM payment. So you may have months where you are billing for APCM and see the patient face-to-face during an E&M visit. E&M visits are billable even during a month which APCM is billed. All right, for our next question, providers must meet and document time thresholds to bill APCM. True or false? Oh, I'm seeing people select option D. You and me both. I need a vacation. I'll give it just another moment. All right. The answer to this one is false. While some care management services such as CCM and PCM do require meeting certain time thresholds, APCM does not. CMS really wanted to relieve the administrative burden of meeting and documenting time for APCM services. While clinical staff providing these services are not required to document or meet time thresholds, they must document the activities or service elements of APCM that are provided. Okay, moving on to our next question. So this question is, who can bill Medicare for APCM? And you can select all that apply from these options. Is it A, physicians, B, non-physician practitioners or NPPs, C, auxiliary personnel, or D, nobody, it's not covered by Medicare? All right, it looks like just about everyone has their answers in for this one. The answer is A and B. APM services can be billed by a physician or non-physician practitioner who is responsible for all of the patient's primary care services and is the focal point of care for that patient. While CMS has not restricted APCM to any one specialty, it is expected that this will generally be billed by primary care specialties such as general internal medicine, family medicine, geriatric medicine, or pediatrics. All right, for the next question. Who may provide APCM services? And you can select all that apply. Is it A, physicians, B, clinical staff, C, auxiliary personnel, or D, non-physician practitioners? All right, the answer for this one is all of these. There may be some services, such as virtual check-ins, that do directly involve the billing physician or non-physician practitioner. However, APCM services will typically be provided by clinical staff under the overall direction of the billing practitioner. CMS does also state that auxiliary personnel are also able to provide APCM services under the general supervision of the billing practitioner. We had a pre-submitted question from Natalie who asked, does the auxiliary staff need to be employed directly under the physician, or can they just be employed by the same entity as the physician? So services may be provided by auxiliary staff under the Incident 2 guidelines. The Incident 2 guidelines define auxiliary staff as any individual who is acting under the supervision of a physician or practitioner and who is an employee, leased employee, or independent contractor of the physician or of the same entity that employs the physician. So they can be employed directly by the physician, or they can be employed by the same entity who employs the physician. We had a couple questions asking for examples of APCM services. Some examples might include post-discharge follow-up by your clinical staff. So maybe they're reaching out to the patient after discharge from an inpatient hospital stay. Or another element is medication reconciliation, management, and oversight of self-management. So maybe the patient calls in one evening after hours with some questions about their new blood pressure medication and notes that they've experienced some mild dizziness. Your nurse speaks to them, providing them with that 24-hour access to care, and reviews with the patient which medications they should be taking along with the proper dosage. So the care that is provided will be specific to your patient's needs and will be documented to show that APCM services were provided. You do not need to document the number of minutes spent, but again, the documentation should show who performed the service and what was done. All right, for our next question. Which of these codes is billed for APCM services provided by clinical staff for a patient who is not a QMB and has 2 or more chronic conditions? Is it A, G0556, B, G0557, C, G0558, or D, G0438? I'm going to give it just another minute on this one. Give everyone a chance to double check these codes. Okay, the answer for this one is B, G0557. This is the second level of APCM services. Remember, we have 3 levels. G0556 is for those patients who have less than 2 chronic conditions. G0557 is for patients with 2 or more chronic conditions. And chronic conditions are those that are expected to last at least 12 months or until the death of the patient and place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. Then we have G0558, which is the third level, and this requires at least 2 chronic conditions for a patient who is a qualified Medicare beneficiary, or QMB. We had a pre-submitted question asking, what if a patient brings up problems outside of their comprehensive care plan during an encounter with clinical staff? And I can absolutely see this happening for APCM services. Maybe the patient has a new complaint and knows they have 24/7 access to care with APCM services. They contact the clinical staff, who then documents the complaints and may seek input from the billing practitioner. Remember that clinical staff provide care under the overall direction of the billing practitioner, who is ultimately responsible for the patient's care plan. It might be a situation where maybe a follow-up visit is needed, or maybe care coordination where they're referred to another provider for further testing. If the care plan is updated and services are provided by clinical staff, it can still be included in APCM. The clinical staff may suggest an update to the care plan if appropriate and send to the practitioner for review and approval. In any case, whatever action is taken should be documented. All right, moving on to slide 18. And our next question. So the next question, all patients require an initiating visit for APCM, true or false? I see a few changing your answers. I know we're kind of split down the middle on this. Some of you are saying true, some are saying false. All right, the answer for this one here is false. An initiating visit for APCM is required only for new patients or patients not seen by the billing practitioner in the last 3 years. And that leads me to our next question. So this next question asks, which of the following may serve as an initiating visit for APCM? And you can select all that apply from these options. Is it A, 99211, B, 99215, C, G0439, or D, G0402? All right, the answer for this one is B, C, and D. As I mentioned on the last slide, an initiating visit for APCM is required only for new patients not seen within the last 3 years. You can count E&M visits, annual wellness visits, or initial preventive physical exams, or IPPE, as your initiating visit, as long as APCM is discussed with the patient during the visit. So that covers our correct answers. B, which is an E&M visit. C is an annual wellness visit. D, which is an IPPE. Now you cannot use option A in this question, 99211, because that is an E&M visit that does not require involvement of the billing practitioner. The initiating visit must be with the billing practitioner, who will be responsible for the APCM services. So any E&M visit level 2 through 5 will work, but not codes like 99211, which don't require the billing practitioner's involvement. Colette submitted a great question during registration, which asked if the patient needs to be seen the same month as billing APCM. And the answer to that is no. There is not a requirement that the patient be seen face-to-face during a month that APCM is billed. These services will typically be non-face-to-face services, such as communication via phone or through a patient portal, for example. The only exception to that is for those patients who do require an initiating visit. The initiating visit must be done during a face-to-face visit. All right, our next question. Sorry, I'm having a little bit of a delay with Slido. There we go. All right, for our next question, patient consent is not required for APCM services. True or false? All right, got a lot of answers in, and 100% of you got that one correct. The answer is false. You must obtain the patient's verbal or written consent to receive APCM services. The consent must include notifying the patient that only one provider may provide and bill for these services in a month, so they cannot receive these services from all practitioners involved in their care. It should also let them know that they are able to stop these services at any time. And then the last thing for consent you want to keep in mind is letting the patient know of their cost. Cost sharing does apply for APCM, so the patient will be responsible for any deductible and copay amounts. And Leanne provided some great examples yesterday of how, even though patients will have these costs, the cost of inpatient hospital stays for a patient far exceeds the amount a patient would pay out of pocket for APCM. The ultimate goal is to help prevent or reduce those inpatient stays, so paying for APCM could end up saving patient copays that would otherwise be required for a hospital stay. All right, on to our next question on slide 21. So for this question, a patient with no chronic conditions is not eligible for any APCM services. True or false? All right, I see most answers are in. We're kind of split down the middle, and a few aren't sure, and that is completely fine. The answer for this one is false. CMS included those three levels or three codes for APCM. The first level, code G0556, is billed for APCM services that are provided for patients with one or even zero chronic conditions. So if your office has decided to provide and bill for APCM services, billing G0556 would include patients with only one or without any chronic conditions. It would provide 24/7 access to care, giving the patient or their caregivers a way to contact your healthcare team. And this helps to provide continuity of care and delivers care in alternative ways to traditional office visits to best meet the patient's needs. This might include system-based approaches to ensure receipt of preventive services, medication reconciliation, and oversight of self-management. So unlike certain care management services like CCM, which requires at least two chronic conditions, APCM can be offered to any of your patients, including those who do not have multiple chronic conditions. All right, we're moving on to slide 22. I apologize, I'm having just a bit of a delay with Slido. All right, for this question, we have a scenario. Betty's primary care physician is Dr. Bob at ABC Medical. Betty also receives care from her cardiologist, Dr. Joe at XYZ Cardiology. Which of the following is true? Is it A, Dr. Bob and Dr. Joe may both bill APCM this month? B, Dr. Bob and Dr. Joe cannot both bill APCM this month. Dr. Joe is not eligible to bill APCM services. Or D, Betty must have at least 4 chronic conditions to receive APCM services. All right, it looks like most of you have your answers in. The answer is B. Dr. Bob and Dr. Joe cannot both bill for APCM services. And this is an important part of the patient consent. We want to make sure that Betty understands that she should not provide consent for multiple doctors involved in her care to provide these services. APCM may only be provided and billed by one practitioner in a single month. So if Dr. Joe submits a claim for APCM today and Dr. Bob submits a claim for APCM tomorrow, Dr. Bob's claim will deny. All right, I have a few more questions left. All right, for this question, what place of service should be used for APCM services? Is it A, location of the patient, B, location where the practitioner ordinarily provides face-to-face care, C, telehealth place of service 02 or 10, or D, let the patient choose the place of service billed? All right, looks like we're kind of split on this one. The answer to this one is B, location where the practitioner ordinarily provides face-to-face care. For example, if the practitioner usually provides face-to-face care in the office, your place of service for APCM would be place of service 11. So even though these services are not typically done face-to-face, you won't use a telehealth place of service. So don't use 02 or 10. You will use the place of service for wherever the practitioner normally provides a face-to-face service. You can find this information in the CMS FAQ for APCM services, and I'm going to show you where that is. So I've pulled back up the CMS Advanced Primary Care Services page that we looked at earlier, and I'm looking still in this last tab here, which is where can I get more information. Once you have this tab open, the last bullet gives us a link to the CMS FAQ, and I'll go ahead and open that up. I'm going to zoom in a little bit. It's always pretty little. So this has a lot of great clarification for any questions on APCM. The answer to this question for our activity can be found down here in the FAQ question number 7, right here. And this tells us that you might provide APCM services in both facility and non-facility settings, and the place of service is again where the practitioner ordinarily provides face-to-face services. Okay, I am going to head back to the presentation And we have just a couple questions left. Our next question is, which of the following are service elements included in APCM? And you can select all that apply. Is it A, coordinate care transitions, B, develop a comprehensive care plan, C, provide comprehensive care management, or D, provide 24/7 access to care? All right, the answer for this one is all of these. APCM includes coordinating care transitions, developing and maintaining a comprehensive care plan, providing comprehensive care management, and ensuring that patients have 24/7 access to their care team. Other elements of APCM include providing enhanced communication opportunities, including non-face-to-face consultation options like phone, secure messaging, or email. And you have the ability to use patient-initiated digital communications like virtual check-ins. Another element is analyzing patient population data to identify any gaps in care. And then you must also provide ongoing communication and documentation of the patient's psychosocial strengths, functional deficits, goals, preferences, and their desired outcomes from practitioners, home and community-based providers, social service providers, hospitals, SNFs, and other care providers. All right, now for our last question. Our last question is, every service element of APCM must be performed each month in order to bill for APCM. True or false? Okay, I think this one may have been a little tricky. The answer for this one is false. Not every element of APCM will be needed every month, as the services provided should reflect the individual patient's needs. For example, a patient may not require care transition coordination during a month if they have not experienced a hospitalization. However, they may contact the practice with questions about their medications and speak with a clinical staff member. In that case, the patient is receiving ongoing care management and communication related to their care plan, even though coordinating care transition was not necessary that month. We had a pre-submitted question which said, the Federal Register makes it clear that the ability to provide all of the aspects of APCM is all that is needed to code it each month, correct? So the Federal Register states that practitioners and auxiliary personnel must have the ongoing ability to furnish every service element, and that not every element must be delivered every single month for every patient. However, ability is simply the baseline requirement to offer APCM services. It's not the sole requirement to bill. So while APCM eliminates the minute-by-minute time logging, it does not eliminate documentation requirements. So the standard Medicare rules still apply. Any service billed to Medicare must be supported by medical record documentation, showing in this case that care management activities were actually furnished during that billing period, meaning you cannot bill APCM in a month where zero care management services were performed. The medical record must reflect the care management activities provided in a given month. Okay, now we do have just a couple minutes left, so I will check in with Leanne and see if we have any unanswered questions in the chat.
Ashley, we do not have any unanswered questions in the chat.
All right, well, thank you so much for everything you've done in the chat, Leanne. I know you've kept busy. So if you do think of any additional questions, you have 7 days from today to submit those. You'll send those to our education mailbox and make sure to include the title of this webinar, which is Filling Your E&M Tank, APCM Review with Interactive Q&A in the subject line. Or again, you can just shorten that up to APCM Activity Webinar or something like that. And that will make sure that those emails come to Leanne and I. Please keep in mind that we are not able to access any claims history, so you will want to contact customer service for any claims related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. The email contains your certificate of achievement. It will have your name and contact hours if you need to turn that in for credit towards continuing education units. Now, if you did not receive the email, a few things may have happened. First, you may want to check your spam or junk folder. Also, be sure to add messenger@webex.com to your safe sender list so that any future messages would show up in your inbox. Also, if you joined by phone only, you would not have received this email as there's not a way for us to capture your email systematically from the attendance record, but no need to worry if that's the case. If you joined by phone, you are able to email us with the phone number you joined with to request your certificate of attendance. And Leanne will be adding that email address to the chat. All right, please take a few minutes to complete the survey. You can tell us what you liked, what we can do better, and suggest topics for future education. Now you'll have a few different options to take the survey. You can use the link in the chat, or when you exit today, you will be prompted to go to an external site, and that external site is the CMS Qualtrics page. And you'll see a prompt that will look like the picture we have shown here with a little yellow triangle. And we included that image on the top right of this slide so that you know this is safe. It's not malware or anything like that. For those that are listening through our website or YouTube, you also have the same opportunity to provide feedback. You will have a survey card at the end of the presentation, and the link is also available in the description. All right, that concludes our webinar. I want to thank everyone so much for participating in the activity. We really enjoy those. On behalf of myself, Leanne, and all of our provider outreach and education team, we thank you for taking the time to join us. We look forward to your survey feedback, and we hope to see you again at future events. Everyone have a great afternoon. You may now disconnect.